screen, right? Actually, you can see my screen, right?
Yep, I can see your screen.
Okay,
Yep.
so my name's Karan. I think we've met a few of the interns, Jordy and I, when we did a little bit of the boot camp about a week or so ago, and then a lot of the residents and so forth, including Johnny Na, we know quite well. So I was going to talk about acute coronary syndrome, and then I realized one of the most common things that we get consults about, or that you guys encounter in medicine, is just working up someone with new onset heart failure. And so that's what I'm going to end up talking about. Sorry if I switch up the topic, but this is a case that is kind of a mixture of a New England Journal case and also someone that I had seen on PCS as a first-year fellow last year. So we'll go through it. I want to try to make it interactive, and I can't see the chat. So if you type something in, Ashley has said she will read it out. And Ashley, you can read everything out. So even if they like boo me, my feelings won't get hurt.
Sounds perfect.
I have Adam Zweiman here. He keeps my ego nice and high. All right. So we're going to go through a case presentation, and I'll just go through how I specifically think about new onset heart failure. Now, this isn't going to be comprehensive by any stretch. My goal is to give as many pearls and a process, because I think it's critical for any chief complaint or anything you guys see in the hospital to have a framework for how to approach it. Okay, so there's a 57-year-old lady. She presented to the emergency department with edema in July 2019. Let's see, Sono's texting me. He said he's looking forward to these pearls. Sono, you're going to be revoked as a chief if you keep taunting me like this. And then so it's a 57-year-old lady, July 2019, and she has edema. So she says this edema first appeared almost 2 years earlier, but it had worsened within the past week, and now it was up to her mid-abdomen. She was previously, about 2 years ago, able to walk multiple blocks without any shortness of breath. But over the past week or so, she can only walk about half a block. And she's reporting orthopnea, PND, occasional sharp chest pains while walking. She's noted that she's gained weight, had some leg pain, but no feverish chills or night sweats, no abdominal pain or bloating, no anorexia, no syncope or palpitations. She's from El Salvador. She came here when she was 45. She got a remote history of TB. Doesn't remember anything about it except that she had TB. She also has this history of back pain and had an episode of Streptococcus viridans bacteremia 2 years ago. It was treated surgically because she had developed a abscess in the psoas muscle and in the epidural space. She's only on Lexapro. She's on PPI. She's on oxycodone for the back pain. She doesn't smoke. No alcohol use or illicit substances. Okay, so that's a lot of information. But we'll piece through this here in a second. But I want to start thinking about how we think about heart failure. I think the traditional teaching is that we break it into these categories of heart failure with reduced ejection fraction, heart failure versus preserved ejection fraction. You learn that from the beginning of med school, and that gets perpetuated through residency on the cardiology services and so forth. And I want to argue that this kind of seems arbitrary, right? So who decided that an EF of 40% versus a 45% versus 30%? Now there's some data obviously that goes behind it, but it's kind of a cutoff, and an arbitrary cutoff. And the traditional thought process is that less than 40% is reduced ejection fraction. What we see is in the data, like I mentioned, is somewhat arbitrary, but the mortality and the morbidity is similar for both populations. Now the treatment is different for each, but and the medications we use and what will eventually guide our therapies by. And it's important to recognize the etiology, but I want everyone to kind of move away from the idea that an EF defines whether someone has heart failure. Congestive heart failure is a clinical diagnosis. You don't need necessarily the EF to make a diagnosis of heart failure. The EF will define whether someone has a cardiomyopathy, but the symptoms are what you really have to focus on. And as we found is that the left ventricular ejection fraction doesn't correlate well with symptoms at all, and it weakly correlates with mortality. So you get this echo report that says the EF is 15, 20%, And Adam, who's currently on consults, will answer and say, well, okay, but what are the symptoms? Because that's the thing that correlates the most. So focusing on the idea of what the symptoms are, what you're learning at the bedside, is more important than understanding what the ejection fraction is. The ejection fraction is a way to kind of guide what you're going to think about etiologies, but it's not going to necessarily predict someone's mortality or their symptoms. Okay, so when I'm initially thinking about someone with heart failure, when I'm thinking about symptoms, you may see in Adam's notes or my notes, or if you're Sono, who's very much a gunner and will get things exactly right, you're going to see that there's going to be clear distinctions. And this is kind of a systematic way to think about symptoms so that we can follow it over time and also think about it in a way that allows good research. So when we will define the symptoms, we define it from NYHA class 1, 2, 3, and 4. Majority of the patients that you'll see on the medicine services are going to be somewhere between 2 and 3. On the advanced heart failure services or the primary cardiology service, you may see someone with class 4. Now, what does this exactly mean, right? These are kind of vague terms. If you look on the right of the screen, slight limitation of physical activity, but do not have symptoms at rest is what NYHA class 2 is. NYHA class 3 is marked limitation. So, I mean, that's very different, as you can see, for different people. So in clinic recently, I just saw someone that had hiked Mount Kilimanjaro, and now he can't run more than 3 miles. That's a marked limitation in physical activity for someone just 2 years ago that was doing hiking Kilimanjaro. So it's a point to say that it's somewhat relative to the patient itself. And there's different ways where we can assess actual formally. It's called a cardiopulmonary exercise, but that's less important right now. So first things first, when I'm thinking about seeing a patient with new onset heart failure, which is what we're thinking with this patient here, one of my first questions is, thanks, Jeff, is what kind of symptoms does the patient have? And the reason is, when I said the LVEF doesn't correlate as much with mortality, the NYHA class does. Now, this is old data. It's from the SOLVE-D study for anyone that wants to memorize trials. So if you know what the SOLVE-D study was, something that studied enalapril. The only point is that this was a study before full-on guideline-directed therapy that we have now. But you can see, if you have NYHA class 2 to 3 symptoms, your mortality at 1 and 4 years in this study was 15 to 40%. It's now decreased with better therapies. But if you look at NYHA class 4, 44 and 64%. The symptoms correlate more with mortality than the actual LVEF. What I'll also do is, and any fellow or anyone, what you all should do is also try to characterize the stage. Now, the ACHA stage is more of an idea to describe that heart failure evolves over time. A is that you are at risk of having heart failure. So someone that may have a genetic predisposition. Stage B is that you have evidence of cardiomyopathy, but no symptoms. So this is someone that may be someone that has like an LVEF of 30%, 40%, but has never developed clinical symptoms of heart failure, orthopnea, PND, paroxysmal nocturnal dyspnea, lower extremity edema, decreased exercise tolerance. ACH stage C is someone that has had heart failure symptoms currently or had them in the past. So if you have made someone a stage C at one point, they don't go back to stage B because they've had those symptoms in the past. This is an indication that things evolve over time. And stage D are the patients on the advanced heart failure service that are end stage and require a specialized therapy like inotropes, a left ventricular assist device, or being considered for heart transplant. You'll see this chart, and I'm not going to go into it in detail, but if you're interns, I'm sure you've seen it as a medical student or residents. I'm sure this is one of the things you teach. Well, again, my initial assessment, so I'm thinking symptoms, trying to characterize the evolution. Is this a person that's end-stage heart failure in the beginning? And also trying to make a quick assessment of their perfusion and their congestion. By perfusion is basically how are they getting blood, cardiac output to the rest of their organs, and congestion, meaning how wet are they? How much fluid are they holding onto? Now, there's different categories that you end up putting it in, including cold and dry, cold and wet. Those are the ones where we are frequently managing them in the primary cardiology service or the advanced heart failure service. You may see predominantly the warm and wet patients on the medicine floors. And then I put some markers at the bottom, and I'll share these slides so you can review it later on. But there's different things that give us parameters. At the bedside, something that you'd be able to tell right away for someone that may have a low cardiac index, low perfusion, narrow pulse pressure. Pay attention to that when you're at the bedside. That is essentially the difference between your systolic and your diastolic blood pressure. That difference divided by your diastolic blood pressure, if it's less than 25, or your mean arterial pressure, if it's less than 25%, is a very, very strong indicator that someone has a low cardiac index, whether their extremities are cool, whether they're making urine, how they're breathing. Cheyne-Stokes pattern is a common thing in someone with end-stage heart failure. And I'm looking for congestions, the symptoms that we were describing about, dyspnea, the orthopnea. For those that are inclined, if they're looking at a lung ultrasound and trying to count the number of curly B lines, which I'm sure the Pulm Fellows or the Cardiology Fellows will surely teach you about. But this is part of my initial assessment, and it's not going to be the focus today, but it's just something that I bring up. So when you see our notes, we organize it by, so we can organize our thinking, the etiology of the cardiomyopathy, the class, the ACCA-HA stage, then the LVEF, whether they're warm and cold, wet or dry. So what we may characterize in a problem is, well, this is a non-ischemic idiopathic cardiomyopathy. You describe their symptoms, you describe the stage, what the LVEF is, and you describe their perfusion and congestion. Because that gives you an assessment, and that will start to then guide what therapies you will essentially give the patient. So I want all of you to try to make that assessment for every patient that you see that you suspect that has heart failure. Now, when I think about a framework for heart failure and thinking about etiology, I don't first think about the LVEF. My first question is, as I'm trying to think about the etiologies, is this heart failure? Could this be something else? Could this be cirrhosis? Could this be nephrotic syndrome? Could this be lymphedema? Could this be a medication side effect, by the way? The patient has all this lower extremity edema, including calcium channel blockers. And then as we go through, my first question is this etiology of heart failure ischemic versus non-ischemic? So 50% in the industrialized world, the cause of heart failure with someone with a lower ejection fraction is ischemia. And then I start to think about my first pass diagnoses. Essentially, these diagnoses will account for about 80 to 90% of causes of heart failure. And I'm always asking myself, is one of these causes the reason that someone is having heart failure? Is it ischemia? Is it hypertension? Is it a dilated cardiomyopathy? And I'll go through some of the examples here in a second. And valvular cardiomyopathy. Is the reason the patient's in heart failure because of aortic stenosis, mitral regurgitation, and so forth? So once I essentially evaluate for those, I'm starting to think, if none of these are showing up, I'm starting to think about my next pass. And there's a wide list. It includes infiltrative processes like sarcoid, amyloid, or if there's a vitamin deficiency, very rarely you'll see, but there seems to be some towns in Italy for whatever reason that have widespread selenium deficiency, and they discover that leads to cardiomyopathy. Is it a congenital component? Is it related to hypertrophic cardiomyopathy? Is this patient postpartum? Is it related to hypothyroidism? Is it a high output? Does this patient have Paget's disease? Is it related to arrhythmia, infection, and so forth? But I'm not necessarily asking all those questions up front. I'm trying to organize initially by saying, is it a first pass diagnosis? And those are the things you want to ask yourselves and think about, what can I do to evaluate for that? So briefly, when we think about ischemia, what this specifically means is that the cardiomyopathy is caused by the fact that the patient had a prior extensive myocardial infarction. A lot of their myocardium is hibernating, or they have severe coronary disease. But it does not mean that just because a patient has obstructive coronary disease, meaning they may have a 50% lesion in the right coronary artery, but their EF is 15-20%, that it's an ischemic cardiomyopathy. When you're trying to think about these things, you have to ask, is the amount of ischemia, is the amount of obstruction proportional to that patient's cardiomyopathy? So just because the patient has coronary disease doesn't necessarily label them an ischemic cardiomyopathy. And if you're thinking about ischemia, as soon as you start asking yourself, could this be ischemia? You have to ask yourself, how am I going to evaluate for it? And am I going to revascularize this patient? The reason I say that is that I'll go through this. I'm not going to go through trials a lot because I think at this point it's not necessarily as beneficial as having a framework. So as you're asking yourself, is this ischemia? You ask, is there ischemic symptoms? But then it's hard to differentiate that from a cardiomyopathy in general, right? Does someone have shortness of breath, they have decreased exercise tolerance. So those can be ischemic symptoms. But things that you should do for every patient is, if you look at an EKG, is there anything localizing that suggests that this could be related to ischemia? By that, I mean, does this patient have old Q waves localized on an EKG? The next question is, if this patient has already had an echo, is there a specific wall on the echocardiogram that looks like it's hypokinetic or not functioning as well as the others? That could be like the anterior wall that may suggest that this patient has left anterior descending ischemia. These are things that you should ask yourself for any patient that you think that has ischemia as a cause of their cardiomyopathy. And then, like I mentioned, you should be asking, how am I going to assess for it? And that'll be a talk for future conferences. But one of the things is, well, what's my pretest probability for ischemia? Is this a diabetic, hypertensive, that has peripheral arterial disease, been a smoker all his or her life? So is a stress test going to be helpful? What if that stress test is negative? Are you going to believe it? So you have to weigh the risks, benefits of cath, and of course the cardiology teams are going to be there to help you guide that. Is the patient's kidney function something they can tolerate? Do they have a contrast allergy? All these kind of things as you're thinking about, how will I potentially evaluate for ischemia? And the reason is that there has been data. There's something called the STITCH trial, and the ES is the STITCH, which is the extension study. So the initial STITCH trial studied patients that were from like 2000, and they were randomized in the mid 2000s, and they published the trial in 2011, or not 2011, sometime in the end of the 2000s. And they looked at, does medical therapy in patients that have EF less than 35% better than surgical revascularization? And what they found is, as you can see, the blue line is CABG and the red line is medical therapy. As they approached about 10 years, there was a mortality benefit that was significant. So the thought process is revascularization is beneficial for a lot of patients that have depressed ejection fraction as a cause of an ischemia as a cause of their cardiomyopathy. Now, since that trial has been published, there's been surgical techniques improved, medications have improved. So that there's a lot that we that may not hold still, but the still general thought process, if this patient has an ejection fraction less than 35%, you think it's being caused by ischemia, then revascularization is something that may be a benefit. Valvular disease is a big one, but they'll be covered in a different conference, and I can't do it justice by just thinking about it right here. But thinking back to our case, this was a patient that had strep bacteremia, so we should be thinking about, could this patient be having aortic stenosis or mitral regurgitation as a culprit of their heart failure? Now, dilated cardiomyopathy now is a very heterogeneous group. There's many different diagnoses. And the misdiagnosis is actually common with this group. They did a study of patients that had heart transplant, and they looked at about patients that had a diagnosis of viral myocarditis or idiopathic myocarditis, and they looked at the autopsies afterwards. And about 17 to 20% of them in different studies, they had a different diagnosis. So it can be hard. And when we think about the viral myocarditis, we're specifically thinking about things like enteroviruses that are cardiotropic, like Coxsackie B. There's all different viruses that can cause it, including adenovirus, CMV, EBV. With this being the time that it is, there's been a lot of literature and case reports and so forth that COVID-19 may cause it. I personally am not someone that believes that the evidence of this is strong. There have been very few studies that have actually showed direct infiltration of the virus into the myocardium. Part of that is the fact that you're not getting biopsies on a lot of these patients. But so it's something to be aware of, but maybe not necessarily as prevalent as we once thought. Now, if you suspect that a patient has subclinical viral myocarditis, our patient that we came in was not describing any fevers, shortness of breath, cough. One of the things to know is that only about 60% of them actually have symptoms. You may not know that they actually have symptoms. One of the things that you should look for on a patient with their EKG is there any evidence of pericarditis? Because usually myocarditis and pericarditis will come together. And so you'll be looking for PR segment depression and ST segment elevation. But one of the big things is if a patient, let's say, comes in the middle of flu season and you're suspecting that they have myocarditis, and as you think it's an acute thing, meaning, and they have newly depressed EF. Arrhythmias are the thing that show up early in these kind of patients, and they can be fatal. So learning pearls about subclinical viral myocarditis and viral myocarditis in general. It's kind of a catch-all diagnosis. We think of one of the major bugs being Coxsackie B, but not everyone presents the symptoms. So it's something that you have to consider as part of your differential. Now, there's all these other causes. You know, I mentioned this patient is from El Salvador. So maybe this patient has Chagas disease. Now, what are some clues that are tip-offs from Chagas is, of course, where they're endemic from, but it's also knowing that Chagas usually doesn't present with an acute cardiomyopathy. The heart failure presents in a chronic phase. And these patients also have significant conduction disease and are highly arrhythmogenic. So when we look at the EKG on this patient, or we're going to get some further history, we want to know, do we have evidence of this? And one of the things that was important to know is this patient didn't have any syncope. Not that it's a sensitive marker, but if someone is coming from El Salvador, syncope, conduction disease on their EKG, and they have an LV aneurysm, which is another finding that can be common in these patients, Chagas disease should be on your differential. HIV is another one. Now, the incidence of it is much lower with heart therapy, and the thought process is actually HIV can have direct myocardial toxicity, but more of it is related to the drug toxicity and the fact that it leads to advanced coronary disease. Giant cell myocarditis, probably not the patient, but if you ever see someone on the advanced heart failure service, you have no explanation for what's going on, and they just have a really aggressive full mitten course, and they have some autoimmune history. It's something to consider. And the diagnosis is only made by a biopsy. It's a pathologic finding that we see on there. Eosinophilic is another one where you have very, very thick walls. It usually doesn't lead to a dilated, but it can. And it doesn't have to be that you have peripheral eosinophilia. These are things, again, that are, when I'm thinking about, not necessarily on the first in my differential is ischemia, hypertension, dilated cardiomyopathy, specifically just thinking is it an idiopathic dilated cardiomyopathy, and valvular disease. There's cardiotoxic agents. Of course, the common ones that we're thought about is anthracyclines. Does anyone know the dose at which anthracyclines, and specifically which anthracycline is the most cardiotoxic? I don't know if anyone's typing in.
No responses yet.
So it's doxorubicin. And so it's important to know the doses that the patients have received in the past as well. So the anthracyclines are a dose-dependent effect, and it can be an effect on basically anyone at any dose, but usually it's a dose-dependent effect. And it's more than 400 milligrams over meter squared, or 700 milligrams over meter squared, that you will get this cardiotoxicity. You have a 20% chance. Less than 400, usually not as risk. Another common thing that we think about is alcohol. But what I want, when you're going through the patient's history about asking them about their substance use, note that alcoholic cardiomyopathy has been shown to also be a dose-dependent effect. And it's usually more than 5 drinks a day for 5 years. That's not a hard and fast rule, but it's important to know it's not just a small alcohol intake. And it should be considered largely a diagnosis of exclusion once you've considered other first pass diagnosis. And of course, there's other things like cocaine and toxin exposures. There's other things like hypertensive, which I said is, of course, one of the first ones. There's tachy-induced cardiomyopathy, basically with someone that's at a persistent heart rate greater than 110 for months. Basically, the heart is running a marathon. It can be common in setting a patient's AFib, flutter. It can be hard to sometimes distinguish whether the flutter and the fib is what's causing the heart failure, or it's a consequence of the heart failure. And so it takes some nuance, and as you get more and more comfortable with these patients, you'll be able to figure it out. One of the things that also leads to tachy-induced cardiomyopathy is something called frequent PVCs. And by frequent PVCs, I mean someone where greater than 10 to 20% of all their beats are PVCs. Something that we see commonly here in the hospital, actually in Maryland, I didn't see it in my residency as much, is that peripartum cardiomyopathy. Now, patients that are in their last month of pregnancy, up until 5 months postpartum, can be at high risk of developing cardiomyopathy. Usually, for the majority of patients, this will completely self-resolve. But if you're in the cardiology consult service and you have a patient you're consulted on that has heart failure symptoms, is a month post-pregnancy, it should be on your differential. Hypothyroidism. If you ever suspect someone with heart failure and they what you would normally expect is if their cardiac output is low, that their body is going to try to maintain the mean arterial pressure, because the cardiac output function of it is the heart rate, by increasing the heart rate. But if you see someone with heart failure symptoms, low heart rate, pericardial effusions, they're waning in and out of consciousness, you should be thinking about whether this is heart failure being caused by hypothyroidism. And something we just almost never will see here, but maybe in the developing countries and in your STEP exams, but not really in real life, is thiamine deficiency, which causes a high output heart failure, where patients are very edematous, they got vasodilation, pulmonary congestion. Okay. And then just as an aside to know that familial dilated cardiomyopathy accounts for about 25 to 50% of cases that have an idiopathic cause. That's a lot of information. And I have some information on some other causes here for slides there, but these are the restrictive cardiomyopathies, including things like amyloid, sarcoid, radiation, hypertrophic cardiomyopathy. Again, these you start to think about with patients that have a preserved ejection fraction or some of the pearls here that are listed here. This is all to say is that there's a lot of causes of heart failure, but the major thing that I want you to ask yourself is it one of these first pass diagnoses? And you should be seeking help with cardiology if you're thinking about, even if you're thinking about one of the first pass, but definitely if you're thinking about one of the second pass diagnoses. Okay, so let's go back to the case. So 57-year-old woman presents in July, right? We're not talking about presenting, now this was pre-COVID, but we're not talking about presenting in December in the middle of flu season or some kind of viral illness or pneumonia that potentially trigger this off. As we know, she's 57, squarely at risk of coronary disease amongst our first pass diagnoses. We also know that she's had symptoms for 2 years. This isn't someone that just suddenly developed heart failure symptoms. So if we're thinking about stages, this is probably someone that's had a heart failure that's evolved over time. When there's a fluid up into the mid-abdomen, we'll talk about that here in a second, what kind of pathology we start to think about. We think about she has marked limitation, right? So this is probably an NYHA class 3. And she has symptoms of left-sided heart failure, where you have orthopnea, paroxysmal nocturnal dyspnea, because you have elevated left atrial pressure. That elevated left atrial pressure gets transmitted to the lung and you get short of breath. And she's describing these sharp chest pain. So in terms of her first pass diagnoses, whether that sharp chest pain is actually an anginal equivalent or not, we're still considering whether ischemia is there. And as we noted, this is not someone that's passing out. If this is someone that was passing out, having syncope, our radar would be up even more, maybe for whether it's one of the first pass, but also one of our second pass. We note that she is from El Salvador because she has Chagas. The tuberculosis, I don't really know how to put it together. The therapies don't really typically lead to any cardiomyopathy, but of course, the fact that she had this bacteremia, that she had valvular disease. And we see she says that she doesn't drink any alcohol or drink any illicit or use any illicit substances. So we're kind of piecing our differential together, but we have, before we think about all the other things and get kind of sidetracked by the fact that she's from El Salvador, we have to first think about, is one of our first pass diagnoses there? Ischemia, hypertension, valvular disease, or an idiopathic dilated cardiomyopathy. One of the things that I mentioned here is that she had ascites now up and through her mid-abdomen and significant peripheral edema. When we hear signs like that, especially with someone that has a lot of ascites or their belly feels like they're just getting bigger, they're full all the time, and they just have a lot of edema, but their lungs are somewhat clearer, or they may not have as prominent left-sided symptom, you should be thinking about, is this something that could be a right-sided pathology? Meaning, is the right side of the heart, right ventricle, being affected more? Is this someone that has restrictive cardiomyopathy, meaning they have a lot of difficulty filling the heart, or constrictive cardiomyopathy, same pathology but different, or same thought process but different pathology, and where they have a lot of trouble filling the heart? And so this patient is describing something in that. So our radar is up before we even know what the ejection fraction is it one of the first pass diagnoses? If it's not one of the first pass diagnoses, they have really prominent right-sided symptoms from what I can tell here. So maybe I have to be thinking about my differential on what kind of things affect both the LV and the RV. Is it ischemia? Is it toxin-induced infection, thyroid, and so forth? So the patient's exam. So the temperature was, she was normal temperature. low-ish blood pressure, but not hypertensive, right? So it's probably not something we're thinking about in terms of someone with hypertensive cardiomyopathy. Heart rate is 100 beats per minute. Not likely to be someone that has mixed edema coma with heart rates in the hundreds. And again, this is just from vital signs, but it's important to just begin piecing through the clues to your diagnosis because you have a framework for which you're going to approach it. Someone that's breathing 20 beats per minute. Everyone puts into Epic that they're breathing 20 beats per minute. Hammer home away, that's not normal. If you're just listening to this conference right now, sit there and for like a minute, breathe 20 times in the minute. You're going to be out of breath. Well, some of you will be out of breath. I'll be out of breath. Adam will be out of breath. Johnny Na may not be out of breath. So it's not a normal respiratory rate. So they in some way have some pulmonary insult. The saturation, though, was normal. She did look comfortable. We always, with someone with heart failure or some history of bacteremia, pay attention to the teeth because that's the most likely location from which they will develop transient bacteremia. And so she had normal dentition. So now we get into the neck and the vascular exam. She definitely has an elevated JVD. I won't go too much into what a prominent V wave means, but that's essentially when the atria are filling, and that can be a sign of significant regurgitation across the tricuspid or the mitral valve. And I put this in here that she had a prominent right ventricular heave. Remember that for Dr. Liu, okay? So this patient has basically the right side of their chest is kind of, you can see it kind of bumping up out of their skin. They're tachycardic. They have this murmur at the left lower sternal border, which can suggest someone has a tricuspid regurgitation murmur or a mitral regurgitation murmur. So it sounds like from the history, from what we know, there's a lot of right-sided symptoms to this patient. Okay, other things. There wasn't any tenderness and couldn't really point out any ascites, but significant edema up and through the thigh, up and through the legs, and into the abdomen. And she had this scar over her back, okay? So before we go for it, I'm gonna ask your guys' differential here in a second. So I'll give you some time to think about what's going on. And I'm gonna do it after I show you the echocardiogram. But some basic things you should consider for any patient that comes in with new onset heart failure. Of course, you're going to send us the CBC, CMP, but there's a couple other things that are helpful to know. So on the CBC, it's helpful to know whether the patient's anemic and whether they're specifically iron deficient. Now, I'm pointing out here that the MCV was less than 80. They do have a lower hemoglobin. And the reason I point that out is that it's been shown with Chaz Hong, who some of you have met, who's a director of research here, that iron deficiency is an independent predictor of cardiovascular mortality in a patient with heart failure. It's just something worth knowing. You know, it's not because we're looking for hemochromatosis, which can be another cause of cardiomyopathy, but it is worth pointing out. Also, the creatinine, of course, compared to what the patient's baseline is, what it's now, is critical to know, but it's also an independent predictor of someone's cardiomyopathy. You're all going to pay attention to the AST, ALT, and especially Billy. In patients with heart failure that's leading to congestion and that's leading to backup from the heart, and especially prominent right-sided symptoms, the first thing that you actually see go up is Billy, and it tends to be an unconjugated bilirubin because you have difficulty essentially if you think about the bile getting into the liver to be conjugated. The NT-proBNP is helpful as a marker over time and as helpful in non-obese individuals as a marker of exclusion of heart failure, but it doesn't correlate in any study very well with the severity of heart failure and I'll put that caveat in the majority of studies. So if someone's, consult calls that we always get is patient's EF is 30%, their NT-proBNP is 2,000, can you come evaluate for heart failure? And the question we'll always have is as I was harping back is what are the symptoms? I want you to focus on the symptoms as a primary assessment, okay? Everything else is ancillary and in addition to that. But the symptoms are the key. If you remember the NYHA class, those are the things that really correlate with someone's mortality. It's appropriate to send a TSH on every patient. This patient had a normal TSH. Their iron studies suggested anemia of chronic disease. And for whatever reason, this patient had a thymine level sent. And I'll talk about that here in a second. but a thiamine level has very little utility in itself. So the patient was started on thiamine supplementation. Always appropriate to send HIV. It was the summertime, but still, given that the patient had this heart failure that was unexplained, we'll go through here in a second, the rapid flu and extended viral panel was sent. So basically, normal renal function, nothing standing out on the CBC, maybe a low hemoglobin, normal creatinine, pro-BNP is elevated, don't have a prior comparison, thyroid disease is not present. An EKG was obtained. And again, when you look at an EKG, especially, you're going to always go about it systematically. But especially when you're evaluating for heart failure, what we want you to do is I want you to look for signs of old infarct, basically Q waves, or if the R wave across the septum doesn't look like it's getting bigger, and by V3, V4, that it gets the largest. If it isn't, it's called poor R wave progression. You're looking for chamber enlargement. Does this patient have evidence of left ventricular hypertrophy or right atrial enlargement, left atrial enlargement? That may suggest that something has been going on for a long time. Is there any signs of conduction disease? Because we mentioned patients with certain types of cardiomyopathy are very prone to conduction disease, including diagnoses like Chagas disease. On this patient's EKG, relatively benign, right? It has what looks like a right bundle pattern, but doesn't quite get as wide as a right bundle there, okay? Other things. Now, there's disease-specific signs, and you don't necessarily have to worry about it, but there's things that you, like with arrhythmogenic right ventricular cardiomyopathy, there's a specific sign, and Brugada sign. But what I do want you to pay attention to is dysynchrony. Basically, if a patient comes in with a new onset cardiomyopathy, what you're trying to pay attention to is if they're having symptoms, especially, is there multiple reasons why they can't maintain their cardiac output? And when you're trying to maintain your cardiac output, you want your atria and your ventricles to contract at the same time. And you also want each ventricle to contract at the same time. Because if they don't, then you don't pump out all the blood at once. So what can lead to dysynchrony? Very long PR prolongation. This patient doesn't have that. What can also lead to dysynchrony? By PR prolongation, this dysynchrony between the atria and the ventricles. Or bundle branch blocks. Those are the common things. So if the left ventricle contracts before the right ventricle, then you don't get blood out to the system in a sequential fashion. It can lead to worsening symptoms. And it can be indicators of cardiomyopathy. So what are we thinking about initially? We're thinking first pass diagnoses. We're asking about symptoms. Once we're asking about symptoms, first pass diagnoses, doing our exam, of course, looking for signs of jugular venous pressure, looking for signs of left-sided symptoms, including rails, and looking signs for right-sided symptoms, including ascites, and peripheral edema. We move on to some basic diagnostics that I mentioned here. On the EKG, you're looking, like I mentioned, these are the key things you're looking for to try to help guide your differential. It's not just to read the EKG, but to guide your differential amongst the first pass and second pass diagnoses. This is the patient's chest x-ray. You can see there is some vascular congestion, but the angles are actually pretty crisp. The pulmonary artery looks a little bit large. This is that area right here. And there looks like some proximal congestion here. That can be a sign in the setting of someone that's right-sided heart failure. Now, this is a PA film. What you notice is they have significant cardiomegaly. So things you're thinking about. What do the lung fields look like? Are there evidence of pleural effusions? What's the size of the cardiomyopathy? You'll pay attention to the trachea. Does it have a steep angle or kind of a flat angle? When it's kind of flat angle, you can think about, does the patient have left atrial enlargement? And you're thinking for that because that helps guide kind of your diagnostics for thinking about what type of cardiomyopathy. So that we've done all this thinking, all this assessment, all this initial diagnostics before even the echo. And that's the point that I hope if I hammer home today is that you should be thinking about all these other things before the echocardiogram even comes, because the echocardiogram is not necessarily the point where you start thinking about heart failure. It's an additional diagnostic when you've already made the clinical diagnosis of heart failure. Okay, so this patient's echo showed a normal LV size and function, marked dilation of the right-sided chambers, and there was severe TR. The tricuspid valve looked normal. The IVC was dilated, and this is mark that says when it's less than 50% collapse and inspiration, suggesting that it's congested. The RVSP was 60, which is a mark of pulmonary arterial hypertension, which will be a future talk. But when it's 60, it's moderate to severe, and that can be caused by the left side or the right side. There was no effusion, and the patient was started on Lasix, but the diagnosis was unclear. So now I'm going to ask for anyone to chime in. Do they think that there's a first pass diagnosis that's still possible for this patient? What's less likely? And what are they thinking about on their second pass diagnoses? I'm going to pick on Johnny. If Johnny's still there.
Hey, Karan.
Hey.
I think if we go back to her story, she sounded like she's still having some maybe angina when she's exerting herself. So I can't fully say whether she doesn't have ischemia. I think, again, you made a great point that her history of this bacteremia, could she have some sort of valvular lesion causing some sort of mitral valve regurgitation? Sure. And then the TTE isn't the best test to look at your left-sided valves. So I think there's a lot of first pass diagnoses here, but you can cross off a lot of things like you've already been doing.
Right. So like, we don't think this is hypertension, right? We don't think this is from a toxin like alcohol or cocaine. I mean, maybe we'll be proven wrong shortly. But there's certainly ischemia, valvular disease as amongst our first pass diagnoses are still possible, right? And then there's plenty of second pass diagnoses that we're thinking of. El Salvador, could this be Chagas? Now, this is not, like I mentioned, I said Chagas usually conduction disease, presents 30, 40 years after the initial infection. You see apical thrombi and aneurysm. You know, anything's possible. Could this be like an infiltrative process? Could this be a restrictive cardiomyopathy? Who knows? So, Sono, are you still there?
Yep. Can you hear me?
Yeah. So what would you do next?
I think the next thing to do would probably, you would start thinking about maybe doing like a right heart cath.
Okay. And why specifically a right heart cath?
Because now you're starting to get concerned with this increased RVSP and trying to figure out where exactly is that pulmonary hypertension coming from. You'd want to maybe get like a wedge and see if there's any kind of left-sided component to it as well. I think that's where I would be going. Yeah.
So I tend to agree with what you just mentioned there. But what did we first say is amongst what's the most common cause of cardiomyopathy in the United States?
So John thought stress test ?
Yeah. So I think that's both of you. I think are exactly right. Because have we fully ruled out a first pass diagnosis yet?
No.
Is ischemia. And it should still be on your differential, right? It's still at least a moderate to low, a low to moderate pretest probability. But you agree, why does this patient have this elevated RVSP? Is it from the left side? Is it from the right side? There are some echo parameters, and you can look at it on the slides for what actually correlate with mortality and so forth. But just pointing out again, it's less so the LVEF as much until you get to lower than like 30%. That matters, but the big things that really matter are related to symptoms. Now, actually, the amount of LV masses tend to correlate with mortality better than sometimes LVEF. But anyway, so what they did was similar to what Sono was thinking. Well, let's do eventually may do this right heart cath, but they were also thinking, well, they have this elevated right-sided pressure. This is a patient. Anyone can really develop a PE. I don't really have risk factors for it, so let's do that. So they did a CTA. They also did a VQ scan, which is a way you evaluate for something called chronic thromboembolic disease. They just sent an ANA, just a screen. Hopefully your rheumatology colleagues or just medicine colleagues in general will tell you, hey, sending an ANA just to screen is poor form, and there should be a specific question or specific symptom that should be guiding you there. But again, this patient's ANA was negative. The tox screen was negative. They were looking, is this actually cardiomyopathy? And looking for nephrotic syndrome, and there was a low amount of protein. They did a continuous pulse ox to see if there's some occult lung disease. That was normal. Spirometry was normal. Continued diuresing, but this patient was still severely short of breath. And so the question remained, well, what do we do next? So they went back to their thought process. What is my first pass diagnosis? Have I fully evaluated for it? And they did right and left heart cath. And I'll show the images here. But there wasn't obstructive coronary disease on angiography. By obstructive, we usually mean greater than 70% in the major coronary arteries or greater than 50% in the left main artery. But if we look at the right heart cath numbers I'll show you here, the mean right atrial pressure was 20. Normal is closer to 6. RVSP was 57/21. Again, not normal. Pulmonary artery pressure 56/21, normally around 24/12. And the wedge, normally less than 12 or less than, in our system's hospital, less than 14, was 21. If you notice, there's all the diastolic pressures in each chamber were equal, which is a pattern that can be seen in restrictive cardiomyopathy, can also be seen in constrictive cardiomyopathy. But as they were doing it, what they saw was that the cardiac output was high and the systemic vascular resistance was low. So now with that information, I'm going to say, okay, is a first pass diagnosis here going on? It doesn't seem to be ischemia. Now, valvular disease is certainly possible, but now what do we do with this cardiac output that's high? It doesn't seem like it's hypertension, and it's not a dilated cardiomyopathy. So we have to go back, all the way back to our, I'm going to go back. One second. I don't know where it's at, but I'm going to go back and I'll click through our next pass. And we're kind of in this category of high output. And I said this patient, for whatever reason, they checked a thiamine level. And they started supplementing it, thinking, could this patient be thiamine deficient? Well, that's not really a way to do it. The actual way to test the thiamine levels, you have to obtain a 24-hour urine. So it's not an accurate measure. But we're starting to think about, well, it wasn't a first pass. So, and we're kind of zeroing in on this high output heart failure. How could that be happening? Does anyone have any thoughts?
Hey, Karan, did they send a TSH in those
It was
first
normal.
labs?
Yeah, it was normal.
Did she have a globulin gap?
No, she didn't. What were you thinking about there?
Just like multiple myeloma. You can often end up with heart failure with that.
Right. So, but that usually won't lead to a high output heart failure unless you develop Paget's disease.
Right.
And why does Paget's disease lead to high output heart failure? Does anyone know?
Don't remember the exact mechanism. I know there was something about like in the bones, like in the ribs, you can form like AVMs.
Yes.
Yeah.
Yes. Excellent.
Rowan is also saying beriberi disease with low thiamine.
Yeah. So yeah, it definitely could be that, but this patient's from America. It's unlikely, and they ended up doing a 24-hour urine, and the thiamine levels were normal. So how do we piece it together? So whenever something gets confusing, right, you just always go back to the bedside and go back to your framework. Okay, not a first pass diagnosis, second pass diagnosis, potentially high output heart failure. What's this patient's history? Had the strep bacteremia, but also had the psoas abscess, had surgery. So you go back to this bedside, and what was found was actually the patient had this very loud, continuous bruit right over her lumbar area. And what likely happened is she developed a fistula after that surgery. You can see there's a connection between the IVC and the aorta on this angiogram. And what the patient had done was they had the fistula closed. Within 5 days, symptoms markedly improved. And then by 6 months, the TTS showed normalization. So a cool diagnosis, but that's not the point of this talk. The point of this talk is that we get there if we go systematically about things. And by going systematically, it's the first slides here. Is, okay, what are my patient's symptoms? How has this evolved over time? What is this? We didn't really talk about this here, but always do this initial assessment. And then thinking about the etiology of the cardiomyopathy. Is it a first pass diagnosis? If it's not a first pass diagnosis, then starting to think about one of your second pass diagnoses. And you go about that kind of systematically, you won't miss things, and you'll have a structured, cost-effective, and patients much appreciated approach to heart failure instead of throwing the shotgun approach to everything. That's one piece of it. That's working up the etiology. future talks we'll talk about the management, especially on the medicine floors and also in the outpatient setting, and as you get to the advanced heart failure sets. I'll send these slides to Ashley to post. You guys can go through it. Everything's just basically on the sides and maybe some notes in my comments there. But if anyone has any questions, I'm happy to take them.
We just have a few comments currently. One is that's awesome, and then another of a GIF of somebody shocked.
Yeah. Was it Adam? Adam would have figured it out.
Not Adam. Naveed and Danny Kim.
Naveed and Danny Kim. Excellent. I wish we could see all each other, but it's good to know that this can continue thanks to your chiefs on Teams and so forth. So again, and my final
question. Sorry, why would an AVF lead to equalized diastolic pressures across chambers from Jian?
And would it lead to that?
Why would AVF lead to equalized diastolic pressures across chambers?
So it's not necessarily that the fistula led to the equalized pressures across it. What likely happened is that this patient was exposed to excessive volume, frequently because of the fistula, and that led to some remodeling in the LV and especially the RV, where it developed a restrictive pattern because they were just exposed to that high level of stress and that volume over time. You removed it, and they were able to reverse that. So if there aren't other questions, final point is the fellows, I'll speak for cardiology, but generally across the board, we love to teach, we love to be of assistance, happy to be of assistance, and just encourage you guys to reach out to us with any questions. But as a basic, not as a but, and as a basic thing, begin to develop frameworks and essentially a systematic approach to different problems.
Hey, Karan.
Yeah.
If I know this patient got a CTA,